Hi, good afternoon, everyone. Can you hear me? Thank you. And everyone can see my slide, what I share on the screen. Okay,
Yes.
thank you. Thank you. So today I am going to talk about management of fall in elderly care. The focus of the talk will be including, thank you for replying to me here, factors influencing fall frequency and fall severity. How are we going to assess a patient after the fall? The medicine related to the fall and what are the examination you need to do and tests, intervention and prevention of fall. And in the end, I would discuss 3 cases of fall patient with you. So what is the definition of fall? So the fall is a kind of event that result a person to non-intentionally coming to rest on the lower level, usually onto the floor. About 1/3 of the people in their own home, they had a fall every year. Rest that can cause the patient to have a fear, injury, they lost confidence, and then dependency and institutionalization and death. It is part of the symptom of underlying serious problem. It is not part of the normal aging process. So what are the factors influencing the frequency of fall? Before we talk about this one, we think about ourselves, why we're not falling over when we walk around. So it gets started with our mind want to walk. So you need to open your eyes and then stand up and start walking. So the mind gets started. So your brain started functioning. So motor neuron, sensory input. So where your feet are. So think about these things. So the muscle need to be functioning well. Neuromuscular junction need to be functioning well. The bones are not broken. Joints are stable enough to walk around. In the meantime, even though we are opening our eyes, the environment is too dark, then we can't see anything and fell over. So that's all these factors influencing the frequency of fall. So that divided into intrinsic factor, extrinsic factor, and stressor component. So intrinsic factor will be including your balance, and that is a multi-system scale, as I said, central nervous system, peripheral nervous system, musculoskeletal system, and joint, and cognitive function should be intact. An extrinsic factor, any uneven surface, anything to grasp when you fell over, the height step, something, the grip on the floor where it's very slippery. Yeah, the stressor is sometimes the people have the comorbidity, they have the lower threshold to fall over. For the elderly patient, especially when they have the postural hypotension or even the gush of wind in the crowd, they can fall over. So after the fall, different people have the severity is different. So after the fall, some people might have the fracture. So those who had osteoporosis, increased risk of fracture rate, and reduced mobility patient, they can't stand up after they fell over. So they are long lying on the floor for the whole night, causing the more injury and high CK, rhabdomyolysis, and hypothermia. after the events of the very severe fall, they lost the confidence. So in these days, we call fall as a multifactorial fall, always call like this. We're not going to use any terms like mechanical fall or simple fall. So what are we going to assess a patient after the fall? We should have a good history and gather information from the collateral as well. So when we ask about the history, we should be able to differentiate between is that unsteadiness or frailty, proper syncope or near syncope. Is that due to the acute neurological problem like the seizure or VPPI? So if the patient is very confused, we are getting the history from the whoever witnessed the fall or the family or the care home. That should be included. The fall circumstances, what are they doing? They are walking around or they just sitting. And the symptom before and after, for example, like syncope, there is no previous warning symptom or not. So they fell over lots of consciousness or wake up any seizure activity. So what's happened after they're able to stand up by themselves? And medication review, including the ETOH history and previous history of fall, that would tell us whether we should think about bone protection, any fracture before, comorbidity, and previous function and performance. So these medicine need to be reviewed, especially for the elderly patient. Polypharmacy need to be reviewing. Those who are on sedation, sedative medicine, benzodiazepine, and hypnotic medicine, any antidepressant, antipsychotic, we will be reviewing for the polypharmacy start and stop. So don't forget to review these medicine for the reviewing of the patient after the fall, especially the hypoglycemic agent, longer acting one, oral medicine, as well as the insulin. So for the examination wise, we should know their functional status. That is what we call the time ups and go test. Usually we did in the outpatient setting. So from their sitting position, we ask them the timing, stand up, and then walk for 3 meters and turn around. Usually it takes about 10 to 12 seconds only. If it's more than that one, that is telling us a kind of part of the frailty as well. And cardiovascular system, we will have to do the line of standing blood pressure, ECG, rhythm, any murmur, aortic stenosis can have the syncope. So musculoskeletal system, we have to examine even for the footwear, all the joints, and neurological examination, not only the central nervous system, but also the peripheral nervous system. So people are talking about what are we going to examine after the fall. So first thing first, at the patient conscious level, and roughly look at the outside, are any bruises, active bleeding, yeah, and then ask them to move their upper limb, lower limb, take it from there, which one you want to go first. But the fall will be included the multi-system assessment, yeah. So the routine test we need to do, the routine blood test to find out whether acute infection causing that kind of fall. So usually we check for our elderly patient, B12 folate, thyroid function, and bone profile, because B12 folate deficiency and hypothyroid can cause a peripheral neuropathy. So these are the correctable one, especially in these elderly patients. For the bone profile, it's the vitamin D level, including the calcium level. And vitamin D deficiency is quite common in elderly patients, and there's evidence suggests replacing it will be reduce the risk of fall. And ECG, whether in the state of heart block or arrhythmia or fast or very slow. For the specific cause, we can request the heart monitoring 24-hour tape and cardiac echo to look into aortic stenosis. The tick table test will come only when there is an unexplained syncope with normal ECG and no structural heart disease. So intervention to prevent the fall. It is not the only one system to fix it. We have to look at all the system, and especially making the minor changes to all the factors is more powerful. So we have to tailor down for the patient which intervention will be mostly useful. So we have to modify the risk factor, especially the environmental factors and the multidisciplinary team approach with the physiotherapists and occupational therapists, strength and balance training as well. For the reducing the frequency of fall, as I said from the beginning, we have to do the polypharmacy review. If they are in the state of postural hypertension, the treatment of postural hypertension. For the elderly patient, the target's blood pressure would be about systolic of 140 to 150. We're not going to be very tight stricting of blood pressure, because if they have postural hypertension, if we keep the target at 120, systolic drop another 20 or 30, they're going into collapse. So the walking aids, environmental assessment, and the vision, and to reduce the stressor. Sometimes this is useful. We have to look at the osteoporosis, whether they are going to need the bone protection. We use the FRAX score to assess the patient, whether they need the bone protection or not. Teaching the patient, sometimes they can have the alarm or the lifeline at home, supervision and change accommodation for them. Like some people might be going into the mini to the same level like bungalow, or some will be ended up in the care home. So in hospital, how are we able to prevent the hospital inpatient fall? We treat the infection if they come up with the pneumonia or UTI. So we have to stop all these incriminated medicine that can cause postural hypertension to patient, and provide a good quality of footwear and walking aids. And there should be good lighting. And if they can't go to the toilet, use the bedside commode. The alambe, the cobber should be in hand for all the patient to get the call for the help. And those who have the higher risk of fall should be closer to the nursing station for the supervision, or another extra staff to be supervising in that bay. So sometimes the intervention are rarely effective. Sometimes they might be even more harmful, like the bedside raise. Patient totally confused, and then they caught up in the bedside raise like this. People, they are in the state of delirium. They might be thinking like this is a step, so they climb over these handrails and they fell over. So that can happen. So if they're very confused, to use the low-lying bed for the nursing staff, and then they should be closer to the nursing station as well. So these kind of intervention using for physical restraint can cause more injury in some of the patient. There can be more bruises and fracture and cause the increased agitation. So another thing is whether we can use the hip protector or not to prevent the hip fracture. The research said it's not very useful in the hospital setting, but it is quite useful in the care home setting. But for the elderly patient with the history of incontinence, that would be a little bit difficult and tricky to use. Yeah. So now I'm going to the case discussion. I will go for 3 cases. So this patient came 77-year-old, came with fall and long lie on the floor. On admission, blood sugar is on the lower side. It's not up to the hypo, I think 3 point something, and AKI. Had a cellulitis on his left leg and started the flucloxacillin. But the patient still continued to have the temperature spiking. The past medical history includes the arthritis, prostate cancer in 2011. He had radical radiotherapy and neoadjuvant, and at the moment he had a bicalutamide monotherapy. Not that polypharmacy, taking naproxen, omeprazole, tamsulosin, and eye drop. So what other question you want to ask? And what's the next step you want to do? Anyone can type it in, please. Blood pressure. Blood pressure is not too bad. I think slightly on the lower side. 95/65. And heart rate of 100. Yeah, we can do the septic screening. Before that, so we have the history of fall. So we need to get there a bit more collateral history. How did he fell over? Or if the patient can tell you a bit more. Prescribed naproxen because of the pain. Yeah, he had a chronic pain in the back. So we need a bit more history and physical examination. Yeah. So when I examine him, his GCS is about 13. He used his tamsulosin for the BPH. Yeah, that can definitely cause a low blood pressure. So his GCS of 13, he is using his left-sided hand. This is before COVID to greet me. So clinically dehydrated, so is septic. Yeah, you're right. So chest X-ray, no signs of consolidation. On admission, he had a CT head. There is no acute. Normally live with wife, mobilized with a stick, no carers. Any other examination you want to do? So the whole body examination you need to do. But the left hand's using rather than the right hand. So I asked him he is right-handed or left-handed. So he is. When I examine him, so I have to, he is in the AAU, the second day of admission. So he's covered with the blanket. So I uncover him and examine. So there is the right elbow is quite swollen like this. So that point we have to ask the orthopedic. It's very painful as well. Oh yeah, this is right. We have to exclude the fracture. There is no signs of fracture. So that is swollen, look like a septic joint to me. So the orthopedic team has come and review after the X-ray. So they took the joint aspirate that grew the Pasteurella, which is sensitive to amoxicillin. So because of that, the joint swelling stays swollen up even with the right antibiotic we given. He had continuing spike in temperature. So the orthopedic have to review him to do another 2 washout for the joint and the bursa. This is an acute medically condition causing him fell over. So Pasteurella, what is the Pasteurella infection coming from? It is usually the cat normal flora. So that can be infected to the human after the cat bite or the cat scratch. So usually that can have the signs of infection. It's not being bitten by the cat. Yeah, I retrospectively asked him whether he had a cat at home. He said yes. Not cat bite. He had been scratched by the cat. So he keep the cat at home because to control the mice at home. That's what's happening. Okay, any other question for this patient? Okay, I'll go to case number 2. 84, admitted with unsteadiness when he walked and swelling around his left foot and pain around that area for nearly 2 weeks. Past medical history of osteoarthritis, history of BPH and that is GORD, gastroesophageal reflux disease. Not many medicine, not polypharmacy. ECG shows sinus rhythm, no acute, no evidence of postural hypertension. And this patient I saw in my ward, on Newington ward. So day 3 admission. So in the notes, it say like maybe posterior circulation stroke awaiting the MRI head. Any question or any further examination you want to do? He doesn't have the CT head on admission, no. Examination of the knee joint, yeah, I would do next step. Any other examination you want? Look at the foot and the joint, yes. That's a very good idea. So when I examine him, he is sitting in the chair. He doesn't look septic. He's very well 84. The nursing staff said he can go to the toilet by himself. So what I start is, let me go to here. So neurological examination. There is no signs of stroke on the upper limb examination, but definitely he had reduced sensation on the lower limb, especially on the left side up to the mid shin. And left knee reflexes, knee joint and the ankle joint reflex absence. Normal cerebellar sign. No other focal neurology test, but he has a Romba test positive. Yeah, so I do examine his leg. He is wearing the good walking shoes, and so we take all these things off and look at the his feet. It is swollen, but it's not red. It is hot to touch. There's no signs of cellulitis. He's able to move his ankle joint. Not much limitation, but slightly painful. So these are the blood tests. All are within normal, CRP of 1, ECG of sinus. And because of that peripheral neuropathy type, no cerebellar sign. And when I examine his leg, it is quite swollen. So I thought it is good to do the X-ray. So this is the X-ray of his left foot. What have you seen? Oh, his knee joint is okay. Knee joint examination is fine. Anyone can say anything about this left foot X-ray? You can't see the X-ray? Can you see it now? It is on the slide. I can see on my slide, but you can't see it. Can you see the slide on? Okay. So this is the left foot X-ray. So these are the metatarsal bone, and this is a calyx bone. Did you see this area with these fifth metatarsal bone with the joint area? No? I think Yalda can't see it, but the other people can see it, yes. So this bone has been degenerative changes a lot. So this is the Charcot joint, you're right. So before that, we have requested all the blood tests, including the syphilis serology because of peripheral neuropathy, screening for the peripheral neuropathy blood test done, and I think this is not stroke, so we requested MRI outpatient only, doesn't need to be MRI head as an inpatient. So nerve conduction study in Brighton, sensory motor neuronal axonal polyneuropathy. So we requested the orthopedic to review. So they advise it is an acute Charcot joint actively because this is quite painful as well as quite warm. So they suggested to do the casting before he going home. He stayed driving, so he doesn't want to wear that cast. So they discharge him and review as an outpatient. So he accepted the walk-in boots to go home with. So the proper examinations required if the left foot has been swollen up. So I think that no one have examined his left foot proper one. Okay, so next, the final case, nearly there. This is the outpatient setting. 78, 2 or 3 fall over 1 year. And there's a 2-bed fall. One is at home in the kitchen, one is outside. There is no warning symptom and no loss of consciousness. There's no symptoms of seizure. So after the fall, oh, sorry, I think. No, this is not me, this is the lady. Sorry. So her husband have to help her to stand up, usually mobilized with the assistance of one. In the past medical history, rheumatoid arthritis, osteoporosis, and recurrent fall. labyrinthitis, and hyponatremia, which is resolved already, and history of pelvic fracture. She is on prednisolone and meloxicam for the rheumatoid arthritis and pregabalin already, and ranitidine and calci-2. I think she's using the ranitidine at that time because of the history of hyponatremia. So on examination, there is no postural drop, blood pressure on lying and 3 minutes after standing. There's no heart murmur on auscultation. Neurologic examination, she had peripheral neuropathy, reduced light touch, and the joint position senses impair. The light touch, that's up to the knee joint on both leg, ECG sinus rhythm. So as an outpatient, we did the 4 screening blood tests and nerve conduction study and refer to the community physiotherapy. So we have to think about bone protection for this patient. So she is already on the steroid and history of pelvic bone fracture. So we should be doing the FRAC score for this patient to see whether she should have the bone protection. According to the NICE guideline, usually if the patient 75 years old and above had a history of fragility fracture, they are automatically eligible for bone protection bisphosphonate. But this patient is still under the care of the rheumatologist. That's why I discussed with the rheumatologist whether they want to change that medicine into the other things or not. So they have been following up this patient, and finally they make a decision they're not going to use steroid anymore because steroid, even with the steroid, her hands are still very swollen and recurrent active disease. So finally she is on lefuronamide. So they are not going into the bone protection. So I discharged her from the clinic. So the diagnosis wise is multifactorial 4 and peripheral neuropathy secondary to the rheumatoid arthritis. So for take-home messages for patients who came in with 4, we should have the proper history. If they are very confused, we should get the collateral history and proper physical examination. And find out the acute and reversible causes of fall. And polypharmacy review. For those patients who have a recurrent fall, we should think about the bone protection and strength and balance training and multidisciplinary team involvement in the management of the fall patient. Any other question? Yeah, if you have no question, that is the teaching of the fall for management of fall in elderly patient. But I think I need to go for another time for the bone protection fragility fracture in next grand round at one point. Thank you. Okay, then, if you have no more question, thank you very much for attending this grand round.